exactly as you're saying, with the last talk of these three is really to see if we can now start to apply what we've learned from how to make CAR T cells and how to use them to one of the most challenging problems in children's cancer, which is brain tumors. And I'm going to focus on this particular type of brain tumor, which is called Diffuse Midline Glioma. And that's a really descriptive term. It exactly says what it is. So it's a type of tumor that arises in the back of the brainstem here. And that's essentially the control center of the brain. It's anatomically a very delicate area, and these tumors don't just grow in one area, but they grow within the normal brain cells. And that means you cannot actually take this tumor out using an operation, so a surgical resection is not an option here. What we can use for these children is radiotherapy, and in most children, for a period of time, and we're talking months, it may stop the tumor from growing. But we know that inevitably this tumor starts to grow again, and this is not a treatment that will provide a cure. We have also done many, many clinical studies to see if any of the chemotherapy agents we have would work for this tumor. But unfortunately, none of those drugs have made any difference. So essentially, we have a type of tumor that is rare, but it does occur in about 300 children within Europe each year, for which we don't have a curative treatment. And we really need to come up with something different. And you won't be surprised that I tell you that CAR T cells may be a good approach to try in this context. Now, the reason that drugs haven't worked very well for this type of tumor may be because the brain is a special part of our body. It's quite protected from infection, but also any other things to go there. And therefore, it's quite difficult for drugs to, when you give them into the vein, to actually reach the brain and reach the tumor, and that we refer to that as the blood-brain barrier. Now, cells are different. Cells are not drugs. They're living things, and you've already seen some videos that Antonio had as well, but here again, you see a T cell at work, so it found what it was looking for, and you can see that it moves around, that it senses what's going on. It can actually also change shape. And therefore, these living things are, in a much better way than drugs, able to actually find their way across the blood-brain barrier and go to these special parts in the body. And we know this happens because leukemia can also sometimes sit in the fluid around the brain, or rarely also actually in the brain tissue. And we know that when you give those children CAR T cells, the CAR T cells can go all the way there and find them. And we also know that if you use CAR T cells in a type of lymphoma that can occur in the brain, again, CAR T cells can be effective in that disease setting. So there is definitely merit in trying to see if you can use this in the context of brain tumors. So then what you need is something like CD19, something that tells apart this brain tumor from other healthy parts of the body, healthy parts of the brain, and other parts of the body. And thankfully, that does exist. And it is something that we were already familiar with from another type of tumor that is not uncommon in children, because neuroblastoma. That's actually a tumor that usually arrives in the tummy. Unlike the name suggests, that's not a brain tumor. But we knew that that expresses lots of GD2, and you can stain for it in the laboratory, and then it gives that brown staining. So on the top left, you see a healthy kidney, just as a reference point. You see no brown, it's normal tissue. And lots of the brown GD2 staining in neuroblastoma. And at the bottom, you see 2 cases of diffuse midline glioma, and you see lots of GD2 there. So that's good. So then we could build one of these receptors, which are essentially detectors that you can input into the T cells that allow them to now find the GD2 on the tumor cells. So we built this chimeric antigen receptor, and we test in the lab if it works, if it recognizes cells that have GD2, but ignore the cells that don't have GD2, that they start to divide and become active. They start to secrete cytokines, which are the sort of the messenger they use between themselves to initiate an immune response, and they should also be able to actually directly kill the cells that have GD2. So once we were confident that this GD2 CAR did this, we then needed to go forward to a clinical study. And this is the clinical study that we have started with support from CRIS. The study is named CARMIGO, which takes just some letters of the overall title, which is CAR T cells targeting GD2 for diffuse midline glioma. So here we do the same as what you've heard before. We started the blood from the patients. We modify them, reprogram in the lab to make them have this GD2 chimeric antigen receptor. And then we prepare the patients, giving a small amount of chemotherapy, not to treat the tumor, because we know that doesn't work, but to prepare the body to receive those CAR T cells, make space, make the body receptive to getting these CAR T cells. And then we give the CAR T cells, and then in these early studies, there's several things you need to work out. You need to work out how many of these cells to give. So we start with a smaller dose, and as we go along, we may increase that if it's needed. And then in this tumor type, we also needed to think about how to give them. So we could give them in the vein, which is the same thing you would do for children with leukemia, because we know that when you give them in the vein, the cells are able to travel all the way up to the brain. But you could also argue that it may be more efficient to give them closer to where the tumor is. So an alternative is to give them in a fluid that goes around the brain. And what we do there is the children at the beginning, but when they come onto the clinical study, get a small reservoir that sits on the top of the scalp, and it has a little tube that goes directly into the fluid in the brain. And that way you can give the CAR T cells that way, but you can also use that reservoir very easily then to measure what's happening, within the brain environment. So you can take some fluid from around the brain to see if the CAR T cells actually go there, if there's evidence of an immune response, and even if there would be some side effects which may happen because the cells are active within the brain, you could use that reservoir to help you to give drugs to manage that. So, and then what we do when we do in these clinical studies, and I really want to highlight this, is that of course we monitor the patients very carefully, we manage any side effects that may occur, but we also take samples as we go along. So we regularly take blood samples, which we can do easily from the central lines these children have, so it doesn't cause them any discomfort to do so. And in this case, we can also regularly take some fluid from around the brain because we have also the reservoir to do that. Then we, of course, monitor the children carefully, and we do MRI scans in this case to see if we see any changes in the size of the tumor. And it's really that whole repertoire of things we do who will help us to try to understand when things are working, why are they working, and also in some patients where we don't see any of the desired effects, what may be the barriers to achieving a response. So the study is still ongoing. So far, we have given these CAR T cells to 5 patients. So it's difficult to give you an outcome at this point, but I think we've learned a lot, and this was a lot of firsts. This was the first time we give CAR T cells to children with brain tumors. We have managed to do that carefully and safely for all of the patients. The side effects that we have seen, which is very much to do with the immune response that we want to induce, because that's how these CAR T cells work, happens as expected, but they were manageable with the drugs that we have to manage those immune activations, and also they were fully reversible, so it peaked and it then went away again. And in some patients, not all of them, we start to see some early indicators that this may work, in the sense that some symptoms get better and sometimes the tumors get smaller on the scan. However, the bar is very high, because we don't want just that, which is a good beginning, but we want a complete response, all the tumor away, and we want it to never come back again. So while we're doing this, and we're learning a lot in these clinical studies, we also started to think about what else may we have to do to make this even better and more powerful. And what may be the differences when you do this in brain tumors compared to, for example, in children with leukemia. So one thing that is different is that when you give these cells to children with blood cancer, you give them in the vein, they immediately find what they're looking for, and then they start to do that thing, become active, divide, etc. When the tumor is in the brain, there is quite a bit more going on. The cells need to find the tumor. That takes a bit of time. So that's something to consider. The other thing is that once they get to the tumor is actually quite a complicated thing. It's not just a bunch of tumor cells, but it's kind of like a whole ecosystem of lots of different kinds of cells. So it's tumor cells, but it's also actually quite a few immune cells, a particular type of immune cells. And in this case, they're not helpful immune cells. These immune cells have been corrupted, if you like, by the tumor to actually hinder rather than help, and actually dampen down or try for the tumor to get away from the attack by the CAR T cells. So we're trying to understand this quite complex tumor environment and understand what these tumors are trying to do to get away, so that we can be hopefully tackling that and being a step ahead. So what we are doing there, and this is work from many groups, including ours, is we are essentially building a whole toolbox, a toolbox of different things that you can introduce into those T cells. So we start first by introducing this chimeric antigen receptor, because that gives them the ability to see the GD2 in this case and find the tumor cells. You can build on that by looking for other things on the tumor, which is probably also going to be helpful in this tumor type. But you can also take it a step further and introduce other things. So you can introduce growth signals. So the T cells come always with the backpack of nutrition for on the way. You can also make them resistant to some of the things that the tumor cells are trying to do to get away. So we have lots of ideas of what we can do. The technology allows us to make these cells more and more complex. But the clinical studies are really important, and what the samples that we acquire along the way, to carefully pick from this toolbox what we need to use to go from seeing some responses into complete responses, hopefully in most of the patients, and also for the tumor not to come back. So that's our vision. That's what we're working towards. And then we take that again to a clinical study, because we can work out quite a lot in the lab, but doing it within the patients is a really important part from learning, how we actually get to effective treatment. So this is what the next study would look like. So we introduce not just the CAR, but other, what we call power-up, modules to make these cells even more potent. And then that brings me to the last part of the slide. This is really to emphasize that this is not my work. It's work of many, many people. People in the lab that are doing the engineering, people in the GMP that make the cells for the patients, and people in the hospital that very carefully look after these patients. It's a huge team of people who I all want to thank. I want to thank the patients and the families who take part in these studies. Without that, we make no progress. And the funders, to CRIS, to support us for making it happen. Thank you.